Good morning, everyone. Well, thank you for the invitations by the organizers. So the debate is, does chemotherapy have a role in the treatment of metastatic melanoma? And this is a picture of a patient. In 2006, patient had mediastinal lymph node, just symptomatic lymph node, also the adrenal gland, and patient received some type of treatment. In January 2007, had some nice shrinkage of tumor. In August 2007, it's about 1 year after, still regressing. Continued on until 2012, March this year, the lesions pretty much, it's hard to see, it's almost complete response. The treatment patient received was the docetaxel plus temozolomide, and patient swears this is not the chemotherapy effect, but she takes 1 shot of tequila every morning with honey, and she's sure this is the reason she's still doing well. But at least from my point of view, chemotherapy she received. No ipilimumab, no interleukin-2. Another patient, 2002, in February, had present with liver metastasis and spleen metastasis. And of course, patient was told she only have 6 to 8 months to live and get your affairs ready. And patient received some clinical studies treatment. In April 2002, started shrinking tumors. October 2002, much improved. And this continued until October 2011. In fact, patient comes once a year still, doing very well with almost complete response. Patient received paclitaxel, dacarbazine, cisplatin. Once again, no immunotherapy treatment patient received. So those two cases are small, the examples I can give you that chemotherapy sometimes can work, even though most patients may not be durable response. The number of chemotherapies available has been tested in the clinical studies. In most cases, response rate between 10 to 20% in phase 2 clinical studies. Phase 3 clinical study, it may go down to 10% or less in many cases. For tamustin, 20% response rate, but it's not available in the United States. And honestly speaking, if dacarbazine has any role in patient with melanoma is questionable. It's not really well tested. The reason is single agent DTIC was never compared to the best supportive care. So even though it may not be a whopping the benefit, but there has been no formal testing there. Also recently, there was the randomized phase 3 study that compared best supportive care with the best supportive care plus cisplatin, vinblastine, DTIC combination to see if the chemotherapy has any effect on top of the best supportive care. But the problem is that this was not really fast accruing the randomization trials because as you can see that most doctors don't want best supportive care as a single agent. This was a German study, and during the study, design was changed so that doctors have choice which one they want rather than the strict randomization. And disease control rate was 8.8% for the best supportive care, and the 28.9% favoring the chemotherapy. Median overall survival was 137 days in best supportive care versus 229 days favoring cisplatin, vinblastine, dacarbazine regimen. And there's no prognostic benefit of CVD because of probably small number of patients and also imbalance in prognostic factors. And I cannot say for sure this is the answer. Chemo is better than best supportive care because it's not really well randomized trials. But when patient had choice or doctor has choice, more than 70% of the patient chose chemotherapy in this second line setting in this clinical study. Doublet or even triplet of chemotherapy has somewhat increased trend of improvement in overall survival, but has never shown overall survival benefit over single agent chemotherapy such as DTIC. And some trials, you can probably some even double the response rate, but yet median overall survival was only a trend, but not statistically significant. And if you're looking at the number of phase 2 clinical studies, most studies, even phase 3 clinical studies, median PFS of DTIC is about 1.6 months, although 2 most recent phase 3 clinical studies had PFS of 2.5 to 2.7 months of DTIC. But most of the phase 3 studies on using the CVD was 2.4 to 2.9 months. So except for these 2 trials, there's some suggestion of improvement in overall survival. or PFS. Another question is, can we add immune therapy to it to make it even better? Is it better than chemotherapy? So over the last 20 years, biochemotherapy that incorporates interleukin-2 in the chemotherapy has been tested. And as you know that the response rate tend to be better with combinations of the biochemo versus chemotherapy itself. But once again, overall survival was not impressive, and there's no statistical difference between those two. So still some controversy exists whether more chemotherapy, more immune therapy combinations of chemotherapy is better than simpler agent. Certainly, when you add more drugs, especially with the chemo combinations, bio combinations, toxicity may be worsened. So use of the biochemotherapy is limited to a certain number of patient populations and also certain centers. And there's a new compound, the combination, so in 2000s. This is the carboplatin and paclitaxel from that phase 1 sorafenib carbotaxel trials. In fact, when you look at phase 2 and phase 3 clinical studies, randomized studies, the median PFS was pretty consistent. It's about 4 months with the carboplatin paclitaxel, some variable doses. In this comparison, the chemotherapy alone group. And all these 4 studies that we can see that PFS is more than 4 months compared to DTIC mostly about 2 months. It appears to me that this combination may be better in terms of PFS. And the most recent, 2 weeks ago, there was the meeting of the Society of Melanoma Research. Phase 3 study of Abraxane versus DTIC was announced. And primary endpoint of PFS showed that the median PFS was 4.8 months of the Abraxane versus 2.5 months of DTIC. And hazard ratio 0.79, p-value 0.04, favoring Abraxane. And disease control rate was a little even more impressive, 39% versus 27%, favoring Abraxane. There was a trend of overall survival, but it's too early to say. Toxicity profile was acceptable. And grade 3 or more adverse events were the most common in neuropathy, 25%, neutropenia, about 20%. And this graph shows this is the actually multi-trial, the meta-analysis with MD Anderson. Patient received number of the combinations chemotherapy with or without interleukin-2. And even though chemotherapy alone group, of which small subset also received interferon on top of that, has some response, and if response is there, a small subset of patients may have a long-term survival beyond 5 years or 10 years. We're talking about 10% of the responders. This is not a huge number, especially if patient had complete response. About 25% of the patients still can maintain the good response beyond 5 to 10 years. So I cannot say chemotherapy is totally useless because this patient will say, yes, chemotherapy worked, and I'm still doing okay after 6 months to a year of treatment. And there's possible benefit of adding chemotherapy to the immune therapy, or especially ipilimumab. This is still a controversy, too early to say much about conclusions, but there was a phase 3 clinical study that compared ipilimumab plus DTIC versus DTIC, which was announced last year, last year. And overall response rate was 15% of the combinations of IP plus DTIC compared to 11% of DTIC alone. Median overall survival was 11.2 months versus 9.1 months of DTIC, favoring the addition of ipilimumab. So that study will show that ipilimumab has effects and clinical benefit. But compared to phase 3 study of ipilimumab alone in second-line setting, the median overall survival appeared to be a little better than 10 months itself, although it's not a direct comparison. So this clinical study, it's difficult to say the benefit of DTIC and ipilimumab. However, there were 2 other phase 2 studies, somewhat larger phase 2 studies in European countries and also in Houston. And it's the combinations of ipilimumab plus chemotherapy, either fortemustine or temozolomide. And it's very consistent overall response rate, 29 to 30% in this combination. Median PFS is more than 5 months of this combination. And also median overall survival looked quite favorable. So once again, although it's not a head-to-head comparison, when you compare these data with the phase 3 single-agent ipilimumab data, looks favorable. Maybe something there for the use of the chemotherapy on top of the ipilimumab. And big question is this: can you even predict some of the responders of chemotherapy? I mean, they'll be the best, but as of yet, there's no predictive markers known for chemotherapy. MGMT expressions for temozolomide, SPARC expression for the Abraxane, and ERCC1 expression for cisplatin has not been really well tested, and there's some controversial results on this one. So in conclusion, the chemo regimen so far has not shown survival advantage over base supportive care because there has been no studies like this. However, no recent developed chemotherapy drugs have been compared to the base supportive care and placebo, and it'll be difficult to imagine in this world of 2012 we're going to have new clinical study to compare chemo versus base supportive care. And median PFS of the chemotherapy combination may be better than single-agent DTIC itself. And also still a small subset of patients on chemotherapy alone may have a long-term survival, not as impressive as the vemurafenib or ipilimumab. So role of chemotherapy, in my view, has limited roles as a first-line treatment as a single agent. Maybe it's possible in combination of some novel treatment may be of value. And more important is that discovery of the good predictive marker of chemotherapy is the key for the success of chemotherapy. And now the development of new technology like nanotechnology to deliver more effectively with less toxic, maybe there's some possible role of the chemotherapy in melanoma in the future in subset of patients. And some combination will be the key for the survival of chemotherapy, such as the right dosing schedules, and also some refined duration of chemotherapy. The duration will be very important. So with that, I'll say my answer to this question is yes, there's still a role for chemotherapy. Thank you.
All right.